Hello, everyone. Welcome to another module of clinical management of DRTB. In this module, we look at DR-resistant TB in special situation. So the outline, we will look at the pregnancy and the breastfeeding. So in this module, we'll focus on the pregnancy and the breastfeeding. The other module will look at the HIV co-infection, with the other two modules focusing on diabetes mellitus and renal insufficiency. For this module, the focus will be on pregnancy and breastfeeding. So we'll look at what is the impact of DRTB in pregnant and lactating mothers. So let's take it back to the impact of TB and pregnancy. So what are the effects of TB on pregnancy? So what happens when a pregnant woman contract TB? So what happens if the TB is untreated on the pregnant woman? It increases mortality on that pregnant woman. So the pregnant woman might die if we don't give treatment at the right time, or we don't give treatment at all. Or it might have an impact on the baby. It might give birth to a baby with a low birth weight or premature birth. And it might have an impact on the baby in terms of mortality. You'll have what you call perinatal mortality. And the other one, it could have transmission to the child. So the child could the mother could transmit the TB to the child. Now, there were, in terms of evidence for safety of antibiotics in pregnancy, for many prescription medication, including antibiotics, the definitive evidence of safety is lacking. So in pregnant women, there are no any studies that are made in terms of its safety. So clinical trials almost always exclude pregnant women. So when they are doing clinical trials, pregnant women are the risk one that are excluded on the trials. Obviously, it's because of the risk to the baby. So the information in terms of the drug safety in this kind of patients, the pregnant patients, their source, it's through the case reports. So whatever reports that are reported in terms of what outcome the patient has after using certain drug, it will be reported. And then also with the case series, where the cohort studies and the meta-analysis, and then always, obviously, with the post-marketing surveillances when those patients are surveyed through. And then the pregnancy registries, they are also being used in terms of evidence for the safety of the drug. So we'll look at in terms of the clinical trials that are almost excluded on the pregnant women. So what happens in terms of the clinical trials? That's all like we just highlighted. Evidence from animal studies form part of the assessment of drug safety in pregnant women. So we use the animal studies, but you'll see later on it has got its own challenges, which are animal studies doesn't necessarily predict the fetal abnormalities in human. So that's where we have a challenge. And then the reason it's because of the different in terms of physiology and the development. So they're different for the animal and the human one. So it poses a problem. And the other one is the doses used in animal studies are significantly higher compared to the doses in humans. So that also it's one of those challenges, especially when you are relying on animal studies. In terms of the dose and the physiological and developmental basis in these patients. Now, what was found was that only 30 of the approximately 1,200 animal teratogens have been shown to be teratogenic in humans. That's a small number in terms of for this to see in terms of its effect on the babies. It was a less in terms of for humans. Now, the FDA, in terms of classification for drug usage in pregnancy, what they highlighted was adequate and well-controlled studies have failed to show the risk to the fetus. And that's the thing in terms of the drug usage. So all drugs, they are high risk in terms of usage in pregnant women until proven otherwise. So animal studies have failed to show the risk. And then there are no any adequate or well-controlled studies in women that are done. That's what we highlighted in the previous slides, that no any control studies that were done in women, especially pregnant women. Animal studies have shown adverse fetal effects or no adequate studies in women, and this poses potential benefit that may warrant use. So you look at it in terms of the usage of it, you look at its potential benefit. So most of it are used eventually. Now, the positive evidence of human risk of those drugs versus your potential benefit may warrant the people to use that drugs because of its potential benefits through its positive evidence in human. So the other positive evidence of human risk, it looks at in terms of risk involved in usage of drugs in pregnancy, clearly outweighs the potential benefit. So that's another classification done by the FDA. Now, in terms of FDA pregnancy categories, what was found that human studies demonstrate no risk, and animal studies demonstrate no risk or no human studies. That's another category. And then the other C, category C, animal studies demonstrate risk with no new human studies. And category D, the human studies demonstrate a risk. And then category X, there's a contraindicated in pregnancy. So those were the categories that were eventually made by the FDA. And then based on that, with their groupings that were previously done, the safety, those are the drugs that were thought to be safe in terms of ethambutol, amoxicillin, fluoxetine, paraquat, and meropenem. Isoniazid, rifampicin, parazinamide, chlorpromazine, fluoroquinolones, ethanolamide, cycloserine, rifaximin, linezolid, imipinem, oracelastatin, and then your group D, which is streptomycin, kanamycin, and amikacin. So in terms of looking at its safety for those drugs. Now, as I said, we no longer using the aminoglycosides, which are the group D1, because of its effect on the kidney and the hearing. But what is very crucial and that we have to take into consideration in terms of DRTB treatment is that the drugs that we are using for DRTB, they might be considered unsafe in pregnant based on the animal studies. Remember, the animal studies is the studies that we rely on in terms of the safety of the pregnant women, even though there's some differences in terms of the doses used here and the one used in human. What is important in this instance, even if they are not safe, this medication should not be denied on a pregnant woman with resistant TB, given that these drugs, they have improved treatment outcomes. So meaning its benefits outweighs the risk. So these patients have to be given these drugs, but also it's been discussed in terms to discuss with the patient their risk in terms of for pregnancy, but they shouldn't be denied at all for usage. Now, in terms of breastfeeding, breastfeeding should be encouraged in women. And then the medication used for treating are not a contraindication for breastfeeding. So for breastfeeding, we need to make sure that we encourage women to breastfeed after also following the infection control measures while breastfeeding. So infection control measures should be followed so that they don't cause any harm to the baby. Now, same principles apply in terms of for pregnant women, where if she qualified for short regimen, you're gonna give it like the non-pregnant one, qualify for a long regimen and rescue regimen. So these are the regimen that apply in pregnant women. So it doesn't mean pregnant women have got their specific regimen. It's the same regimen used in the non-pregnant individual. So we use the same principles in terms of a short regimen, long regimen, and rescue regimen. Now, the important part that we have to note is that pregnant women with resistant TB can be initiated on treatment by providers without involvement of the committee or the aspect, especially if the individual is trained to initiate. They could initiate without any approval from the committee. But what is important is also to let them know about the case so that it will help in terms of data collection to national level. So they have to be aware of those cases. Now, what is also important is that all non-pregnant women of childbearing age, if they are on RRTB treatment, you need to offer family planning as part of the return. You remember when we were doing monitoring that family planning plays a part. So you need to be offering it as baseline whenever the patient comes, and then offer those family planning in terms of making sure that we don't want a patient to become pregnant while on RRTB treatment because of the drug challenges that we highlighted in the previous slides. Now, what about in terms of lactating women? Just as a reminder, you remember the effects of TB that we highlighted in the first slides. That if TB is untreated in pregnant women, it increases mortality in those women, and then they deliver babies with low birth weight. They might deliver premature babies, and those babies might die, or they might get TB from their mother. So TB have a greater maternal and child morbidity if there's a co-infection with HIV. So if there's a patient with co-infected with TB and HIV and pregnant, it's got a high mortality to both the mother and the child. So child morbidity in terms of TB treatment. Now, this is one of the risk from TB in terms of the pregnancy. So they look at it in terms of risk per 100,000 pregnancies. So what was found was that low birth weight babies was less than 2.5 kg. If they are born from mothers without TB, they found that 500 of them had low birth weight. So women without TB, pregnant, the babies, they develop 6,500 babies had low birth weight. Whereas mothers with TB that were pregnant, it was almost a double of this number. It was 34,200 of the babies that had low birth weight. Whereas in terms of prematurity, mothers without TB, pregnant mothers without TB, 11,100 babies were premature. Whereas if the mothers had TB, 22, double of them. So this shows the risk in terms of what TB does in terms of the babies. The small for dates, it was 7,900 babies from the mother who had no TB, but with mothers with TB, 20,200, almost tripled this ones with normal in terms of the number. Pre-eclampsia on those women, 4,700 of the pregnant women had eclampsia without TB, and then those with TB, 7,400. It's a higher number. So that shows the impact of TB on these women. Those pregnant women who had vaginal bleeding, 2,200 for those who had no TB, but those who had TB, it was a double of the number. The perinatal death, babies dying with mothers without TB were 1,600, but those with TB, the death, they were 10,100. So it was quite a higher number. Fetal death, especially when they were at this gestation, 16 to 28 weeks, 230 babies died without the mothers with TB, but with TB, 2,000 babies died because of the TB. So what happened, there's very limited data on the effect of TB disease during pregnancy in HIV infected. So this data was not including the HIV pregnant co-infected. So in terms of mother-to-child transmission of TB, what do we know? Now, what happens in terms of adjusted maternal infant mortality rate within the first year postpartum by maternal death? Now, in these mothers, the one with maternal TB, there was mortality of them was 0.9, a bit higher than those without TB. Okay, so they had a slightly higher mortality compared to those without TB. But in terms of the children, a first year postpartum, we had those who had TB, they were 8.5, higher than those without TB postpartum. So that shows the effect of TB on these children postpartum. Okay. So why are these infants dying? So most of them, 50% mortality is due to congenital TB. How do they get the congenital TB? It's through in utero. It could be through hematogenous, through the blood, or aspiration or ingestion of infected amniotic fluid while they are in utero. Now, during delivery, or intrapartum, they could aspirate or ingest the amniotic fluid or genital secretion. So that's how these children can get congenital TB from their mother in these two forms, in utero and then also intrapartum. So this was one of the journals that was showing the number of cases of tuberculosis in women of childbearing age, which has increased 41% in United States between the year of 1985 and 1997. This was a data that was offered from the Center of Disease Control and Prevention. So it shows also the risk of TB in pregnancy has probably also increased, leading to increased risk of congenital TB. So this was one of those new journal in the New England Journal of Medicine that gave in terms of the status of congenital TB. Now, this slide is talking about the diagnostic criteria used for congenital tuberculosis, where it's described by Bates in 1935 and with revised by Cantwell in 1994. Now, it's a bit challenging to prove the presence of TB in children, but they were using the following measures in terms of the diagnosis. The lesions in the newborn baby during the first week of life. It could be also suggestive of your congenital TB. Your primary hepatic complex or your cystatic hepatic granuloma. So they look at your liver, the baby's liver, in terms of through sonar. If there were any changes or any hepatic granuloma on this, that also could give them in terms of a sign for congenital TB. Your tuberculous infection of the placenta. So also during delivery, when they examine the placenta, it could have some signs in terms of tuberculous infection on this placenta that could be a bit abnormal. Or they look at the genital tract of the mother post the delivery. Also, that could also give in terms of the sign of congenital TB for the baby. So exclusion of possibility of postnatal transmission by investigation of contacts, including hospital staff. So also they looked at in terms of the contacts and even the staff that were busy with the mother. They could also look at in terms of contacts to make sure that they were not transmitted in terms of TB after delivery. Now, it is estimated that 50% of babies born to mother with active TB disease will develop TB disease during the first year of life if IPT or BCG is not provided. So it's very much important to examine those babies and follow up those babies and provide appropriate prophylaxis on those babies or immunization on these babies. So in the other hand, if any is given blindly without ruling out TB, you're going to cause problems on these babies. So before INH is given on this, you need to rule out TB on these babies, and we're just going to talk about in terms of how you rule out it. So the mortality of congenital TB disease is over 50% in these babies. So it's very, very high. So meaning if you have two babies, one of them is going to die of congenital TB. In terms of your clinical presentation of congenital TB, it's not specific, as I said, but it's usually marked by involvement of many organs on the baby. So your examination will look at the chest X-ray of the baby, and you do some gastric or bronchial aspirates of the baby. You take it for microscopy and culture, and then also your gene expect. You could also take tissue on the baby for histological diagnosis. So those are some of the measures that you have to take to exclude the congenital TB on a child before you try and offer IPT on the child. So the other measures that could also assist with diagnosis is the evidence of TB infection on the maternal genital tract. So if you see any abnormalities on the genital tract of the mother post-delivery, also remember that you examine your placenta. If you see any abnormalities on the placenta, that could also be a giveaway. The other one is the strain of isolated from the neonate must be the same as that from the mother to prove that it's a congenital or she got it from the mother. Now, this is how you manage a baby post-delivery of a mother with a TB. So there are three scenarios that you are going to be looking at. Now, the first scenario is if you have an asymptomatic neonate born of mother with infectious drug susceptible TB. So this is one of your susceptible TB where your mother is on the normal or the commonly called Rifampicin treatment. So it's got a susceptible TB. So what do you do with that baby? You are going to treat the baby with the TB treatment, your rifampicin, isoniazid, and parazinamide treatment. So you're going to give them the 3 drugs for a period of 6 months. And at the end of the period, you screen the infant for TB. If negative, BCG must be given after 2 weeks. So with these cases, you're going to withhold BCG at birth. You're not going to give BCG at birth. You're going to give it after treatment, 2 weeks after treatment. So it's going to be withhold here because you're starting the child on TB treatment. Whereas asymptomatic neonate born of mothers with infectious drug-resistant TB. Now, these ones are what you're going to be doing. If a child is well, you're going to give prophylaxis after excluding TB on the child, doing X-ray and an aspirate. You're going to give prophylaxis INH 15 to 20 milligrams daily for 6 months, and you follow up the child monthly, aiding pyridoxine on that child. And then if the child is well, does not develop any signs of TB whilst on prophylaxis. So you have to monitor the child monthly to check if there's any signs that are developing on the child. The child is maybe not eating well, not playing well. So you have to bring the child back to the facility. If the child is well, you continue prophylaxis until the end of 6 months. You stop prophylaxis and give BCG 2 weeks after. So even with this one, you're going to withhold BCG at birth. Then you're going to give it 2 weeks after. But if TB develops while on prophylaxis, you refer to MDR unit because the source case has got a drug resistance. So they have to look at in terms of the pattern of the resistance on the source case. The next scenario is when the neonate is asymptomatic and born with the mother with non-infectious drug susceptible TB, meaning it's extrapulmonary. So you screen the infant for TB clinically and radiologically through X-ray, your gastric aspirates, clinically if the patient is gaining weight, not gaining weight, is not sick, is playing well. So if in that case, no TB is confirmed, they're all negative, you give isoniazid 10 milligrams per kilo for 6 months. And even here you withhold BCG, you give it 2 weeks after completion of isoniazid. But if TB is confirmed or infant has got signs suggestive of TB, a complete TB treatment must be given. And then withholding BCG and giving 2 weeks after completion of treatment. So this is an overall in terms of how you manage babies born to mothers with TB to avoid babies having congenital TB. Thank you.